syphilis. There will be a Q&A at the end of the event. Please keep questions broad. All questions should be posted in the question box. When asking questions, please hit the Remain Anonymous button in the bottom left-hand corner. Your presence on this webinar is completely anonymous, and your video and voice are not enabled, and attendees cannot be viewed. It is with greatest honor that I get to present Dr. Gerber. Sharon Gerber, MD, MPH, FACOG, is an OBGYN and board-certified complex family planning subspecialist. She is the Director of Complex Family Planning at Northwell Huntington and South Shore University Hospitals. She is a fellow of the American College of Obstetricians and Gynecologists and member of the Society for Family Planning. Dr. Gerber is an assistant professor at Donald and Barbara Zucker School of Medicine at Hofstra, Northwell, and enjoys mentoring medical students interested in family planning. Dr. Gerber is committed to expanding abortion access on Long Island. She's creating a Ryan program for the residents at Huntington and South Shore University Hospital, and is setting up a partnership with other programs to train residents from states with restricted abortion access. Dr. Gerber has dedicated her professional life to maintaining and expanding access to comprehensive reproductive care. In her personal life, she is a devoted wife and mom of 2 active little boys. Thank you so much for speaking with us.
Thank you for that introduction. Give me a moment to share. Okay, so I'm going to be introducing sexually transmitted infections really across the US and what that looks like. And I'll be talking about gonorrhea, chlamydia, and human papillomavirus, or HPV. So that you know, all the information that I am presenting here is from the Center for Disease Control, the American College of Obstetricians and Gynecologists, and the United States Preventative Task Force, which we're going to talk a little bit about epidemiology. What does that mean? It means where things come from and how prevalent they are. Modes of infection. So how are these infections transmitted? And like I said, we'll talk about gonorrhea, chlamydia, and HPV. And all of these things. So we want to talk about transmission, symptoms, complications, what somebody may see on an exam, how we screen people, and how these are treated. So sexually transmitted infections remain common, and they're actually very costly to the nation. So prevalence means in one given time, how many people have an infection. So 1 in 5 people at any given time has a sexually transmitted infection, and that's nearly 68 million infections in the United States. So the incidence is how many new infections we have. And that's about 26 million yearly. This comes from 2018. And it's also costly. So direct lifetime medical costs are about $16 billion. You can see here that human papillomavirus accounts for the majority of sexually transmitted infections, followed by herpes, trichomoniasis, chlamydia, gonorrhea, and HIV, and hepatitis and syphilis. And so when we talk about viruses, human papillomavirus is the most common virus, and then chlamydia is the most common bacterial infection. So a little bit more about cost. You can see how costly HIV is to the healthcare system, and that's followed by HPV and then all other STIs combined. Care for women, excluding HIV care, accounted for 75% of all STI-related direct costs. So this disproportionately affects women. In 2020, over half of reported cases of chlamydia and gonorrhea, primary and secondary syphilis, were among young people, 15 to 24. And that is so important when we talk about screening, because it is so important, and the guidelines are set to screen people younger than 25 routinely, especially for gonorrhea and chlamydia. Overall, the incidence of STDs reported is actually increasing. Chlamydia has gone down, I think, by about 50%, gonorrhea increasing, and then primary and secondary syphilis have actually been increasing tremendously, primarily by something called maternal to child transmission. So that's from transmission during pregnancy. When we talk about modes of transmission and we talk about sexually transmitted infections, this isn't just penetrative penis vagina sex. There are multitudes of different forms of sex: vaginal sex, oral sex, anal sex, not sex, but what I was saying before, mother to child transmission. That can be during pregnancy. It can be during childbirth through the vaginal canal, or through the vaginal canal and then touching skin, through breastfeeding. And then we also have other forms of sexual activity, so intimate skin-to-skin contact or genital contact, hand-to-genital transmission, and also sharing sex toys. So chlamydia is, as I said, mentioned before, is the most common type of sexually transmitted infection that is a bacteria. And it targets cells that are actually found in the genital tract. It can be transmitted through vaginal sex, anal sex, oral sex, and sex toys, and as well as manual stimulation of the anus and the genitals. So there is anal chlamydia, and that can also be symptomatic as well. And then MTCT is maternal to child transmission, and that's transmission during childbirth. Chlamydia actually affects 1 in 20 sexually active people under 24. And so that is also why screening is so important. So what are the risk factors for chlamydia? So if it hasn't been obvious already, age younger than 25, having multiple sex partners, being in a non-monogamous relationship and not using condoms consistently, anyone who's involved in sex work or transactional money for sex activity, or any history of a sexually transmitted infection. So once somebody has a history of a sexually transmitted infection, the guidelines say to treat for all sexually transmitted infections, to screen for sexually transmitted infections every 3 months. So those are people who want to get continually checked on an ongoing basis. So chlamydia primarily affects the genital tract. So what is nearby is also the urinary system. So sometimes, while chlamydia is most often asymptomatic, meaning you actually don't know that you even have chlamydia, and a clinician can't tell you based on symptoms, there are many common symptoms of chlamydia. So that can be pain during sex, pain in the lower abdomen, pain during urination. It can also cause a conjunctivitis. That can be from, genital to face contact or from oral sex as well. There's something called cervicitis, which is an inflammation of the cervix. And cervicitis, anytime the cervix is irritated, it can cause bleeding between periods. So you can have intermenstrual bleeding, and then also a vaginal discharge. Untreated chlamydia can cause complications. There's something called pelvic inflammatory disease. That can be symptomatic, pain in the pelvis, but if you were to look inside the pelvis, it can cause scarring. That scarring can lead to infertility, sometimes an ectopic pregnancy, so a pregnancy that's in the tube. It can cause chronic pelvic pain, premature birth, and then with maternal to child transmission, an untreated baby can get conjunctivitis, even blindness. There's also something called a reactive arthritis, which means it can actually affect the joints if it goes untreated. There's something that we learned in medical school called can't see, can't pee, can't climb a tree. So if those symptoms happen after some sort of genitourinary infection, It doesn't necessarily mean that it is chlamydia, but chlamydia is one of the more common things that can lead to this triad of symptoms. So on the left-hand side here, you have what a normal cervix looks like. And on the right-hand side is a cervicitis, so inflammation of the cervix, and it looks like a little bit of discharge. Often, people who have chlamydia don't have a cervicitis, and they look like they have a normal appearing cervix. So again, it can be, oh, here we go. So in reality, the majority are asymptomatic, and that's also why screening is so important. So who do we screen? We screen women aged 15 to 24 and 25 if they're at increased risk. And that's your group who have a previous or coexisting sexually transmitted infection, non-monogamous relationships with inconsistent condom use, history of sex work, history of incarceration as well. And there are multiple ways to test for chlamydia. And so the different tubes here represent the different ways. So you can actually do a self swab, so a vaginal swab. I often do these for teenagers, for people who've never had a speculum exam before and they're asymptomatic and it's just part of my routine screening. They can do a self swab. You can have a clinician do a speculum exam and swab the cervix. And you can also test by urine. So that's another common way that I test. Chlamydia screening is recommended in pregnancy to screen at the first prenatal visit. For anybody who does have chlamydia during pregnancy, because of mother to child transmission, there's something called a test of cure, and a test of cure is done 4 weeks after treatment. And again, just like the general population, the recommendation is to retest every 3 months. And then you retest in the 3rd trimester if they're high risk, and at delivery if they've never been screened. So most people will get screening at some point during pregnancy. So how is it treated? The CDC actually just changed their guidelines. The preferred treatment is doxycycline twice a day for 7 days. The alternate is azithromycin 1 gram orally in 1 dose, which is actually much easier. And this recent change came from data about the efficacy of these antibiotics in gay men more so than women. So I still go by the CDC recommendation, but if people have difficulty or I'm not sure that somebody will follow up, then azithromycin is a good alternative. It's also a good alternative for something called expedited partner therapy. So it is, different states have different laws. So it depends on which state you're in. I live in New York, and in New York, we have expedited partner therapy for both gonorrhea and chlamydia, where I can ask a patient if they would like treatment for their partner or partners, and I could send the prescription to the pharmacy. I'm going to switch gears now and talk about gonorrhea. So gonorrhea is the 2nd most common bacterial sexually transmitted infection, with about 1.5 million new cases a year. And this is also transmitted in a similar manner: vaginal, anal, or oral sex and sex toys. Again, manual stimulation of the anus and genitals, and can also be transmitted from mom to baby during childbirth. Oh, here we go. So this compares gonorrhea to chlamydia. And even though, again, you see that the biggest age group is that 20 to 24-year-old age group, there's still chlamydia is far more common than gonorrhea. Risk factors are going to be the same as chlamydia, with the addition of recent international travel. And that's because gonorrhea is more clustered than chlamydia. Chlamydia is rather ubiquitous. Symptoms, again, are going to be very similar: painful urination, abnormal discharge, vaginal bleeding, and that's, again, inflammation of the cervix, cervicitis, that's going to happen. It can also cause the same types of complications as well. So we talked about pelvic inflammatory disease, infertility, and that's all with scarring of internal organs. So essentially what it does with both of these is it travels up the genital tract into the uterus, basically through the tubes, and can cause the scarring and inflammation inside of the pelvis. And you can get systemic infection. And you see here, this is a gonococcal arthritis. So arthritis can happen from sexually transmitted infections. And once again, with maternal to child transmission, blindness, sores, and other types of infection. This is what we call mucopurulent. So this type of discharge that it looks almost like pus. So that would be a telltale sign of an infection, not necessarily just gonorrhea. This is gonococcal conjunctivitis. And you can see that also has that mucopurulent discharge. It looks like pus draining from the eye. And again, in the reality, the majority are asymptomatic. And that is why screening is so important. Everybody who comes into the office under 25 gets screened for gonorrhea and chlamydia. And then anyone with a recent sexual activity, a new partner, if they haven't been tested before, it's important to get tested. Anybody with a history of a sexually transmitted infection, again, they should be getting tested every 3 months. So uncomplicated gonorrhea, the treatment is ceftriaxone 500 milligrams IM. That means intramuscularly for a single dose in people weighing under 150 kilograms, which is about 300 pounds. For people weighing above 150 kilograms, you do twice the dose. This is interesting because, as I mentioned before, the CDC recently updated their guidelines. And this is double the dose than the previous guidelines because there was a lot of gonorrhea that was not effectively being treated. If a person has only been tested for gonorrhea, then you just assume that they have chlamydia and treat as well. Most of the time, and the majority of commercially available tests do test for both at the same time. So you would have the answer about chlamydia. These are some alternate regimens because the type of drug that is used to treat gonorrhea is a drug that more people are, or not more, has a significant amount of people who have allergies to it. And again, I live in New York, and New York expedited partner therapy is legal. So any sexual partner within the last 60 days, and if they haven't had a new sexual partner in the last 60 days, then it's the last sexual partner that they've had. So HPV, there's a lot of information about HPV out there, and it is the most common sexually transmitted infection, with 43 million cases in 2018. So likely you know somebody who has HPV. There are 13 million new infections. This was for the data from 2018, 13 million new infections in 2018. The good news, 90% will go away within 2 years. And again, transmission, vaginal, anal, oral sex toys, but this can also go through from skin to skin transmission, which makes transmission much more easy and much more common, which is why it's the most common sexually transmitted infection. This is an example of a genital wart. Most people actually don't know that they have HPV, but if they are symptomatic, it will come up either as a wart or in an abnormal pap smear. I wrote here, no FDA test approved for oral pharyngeal disease. And that's because you'll hear that. So HPV is responsible for 70% of vaginal and vulvar cancers. over 90% of anal cancers, because it's common in the among men who have sex with men, and also 70% of oral pharyngeal cancers. So we do screening for cervical cancer, usually with a gynecologist or primary care physician, but there is no screening for oral pharyngeal cancer. It can usually be detected early when seen by a dentist or healthcare provider. So complications of HPV, it can lead to genital warts. So prior to the HPV vaccine, about 340,000 to 360,000 people had genital warts yearly. 1 in 100 sexually active adults in the US has genital warts. Regarding cervical cancer, as I mentioned before, about 70% of vaginal and vulvar cancers are attributed to HPV. 12,000 women living in the US will have cervical cancer every year, and over 4,000 will die from cervical cancer. So the ACOG and United States Preventative Task Force recommend cervical cancer screening. So that is the pap smear, starting at age 21. It does not matter if somebody is sexually active before 21. Why? Because young people generally have very robust immune systems and can get rid of that HPV. As I was saying earlier, 90% will go away in 2 years. The recommendations that I'm giving now are for people who, the general population, normal immune systems. From age 21 to 29, it is recommended to do cytology alone every 3 years. So back when I was a medical student, people were doing pap smears every year. That is not the case now. And I remember I would have people who are shocked. I don't need a pap smear every year. No, you do not need a pap smear every year. So this is 21 to 29, every 3 years, a pap smear. Then there's also separate HPV testing. So between ages 30 to 65, you can either do just the pap smear alone, looking at the cells of the cervix every 3 years, or you can do a FDA-approved HPV testing only every 5 years, or co-testing, doing both of them together every 5 years. Again, those are the guidelines. If it's normal, repeat 3 to 5 years. And you can actually stop at 65 if there have been, if the previous 3 pap smears have all been negative. And then if somebody has had a hysterectomy, meaning taking out the uterus with, their cervix out, for benign disease, meaning something that's not cancerous, then they actually don't need to get screened anymore. So there's no treatment for HPV. HPV can just be dormant, or sometimes it goes away. But we do need to treat the health problems that are caused by HPV. So if that's genital warts, there are topical medications. Therapy is freezing, electrotherapy, excision, taking it out, or laser therapy. And then obviously if somebody has cervical cancer, that would require surgery. So we focus on primary prevention. In medicine, primary prevention means preventing something before it happens. So there is a vaccine for HPV. It is recommended for all preteens starting at age 11 or 12. You can start as early as 9. If the vaccine is started before age 15, only 2 doses are needed. If after age 15, then it is a 3-dose series. And it is recommended that everybody get it through age 26, up to 26. So if somebody comes to my office and they were not vaccinated by their pediatrician, I can do what's called vaccine catch-up up to age 26. Now, recently, and it was in the news, that there is a benefit to vaccinating after age 26. So studies were done from people 26 to 45. And so you have a conversation with the patient about the risks and benefits of vaccinating after age 26. And really, the risks are very minimal. It's your typical vaccine risk of pain at the injection site. It can cause a very sore arm, but not really like fevers as you would with like a flu vaccine. So really what I talk to people about is whether it's covered by their insurance company. If they've been in a long-term monogamous relationship, then it may not be necessary. But if somebody is single or newly divorced and they were not vaccinated, then it may be something to consider. So this is all shared decision-making. That concludes my portion. I am going to turn it over to Dr. Machefsky.
Thank you so much, Dr. Gerber. It was really informative, and I think we all learned a lot. And now it is with great honor I get to present Dr. Machefsky. Dr. Machefsky, Aliza Machefsky, MD, is a board-certified OBGYN and an assistant professor in Emory University's Department of Gynecology and Obstetrics. Prior to this position, she was the Gilstrap Fellow within the CDC's Division of STD Prevention. In this role, she provided subject matter expertise on sexually transmitted infections in women and pregnant patients, with a specific focus on congenital syphilis screening, diagnosis, treatment, and prevention. Dr. Machefsky completed a residency in obstetrics and gynecology at St. Louis University. She holds an MD from Drexel University College of Medicine and a BA from the University of Pennsylvania. Thank you.
I'm going to share my screen now. And my presentation. Can you see it? Asnat? Can you see? Okay, perfect. All right, so with that, it's an honor to be here. Thank you for that wonderful introduction. And I'm going to sort of wrap this conversation up with a conversation on genital herpes and syphilis. I have nothing to disclose here. So let's start with herpes first. Genital herpes specifically is a chronic, lifelong viral infection. So Dr. Gerber was talking about bacterial versus viruses. This is a virus. And there's two types of herpes simplex viruses, or HSV is how we abbreviate it. There's HSV1, which also causes the common cold sore that you'll get on your lip. And then there's HSV2, which is traditionally thought to be more of the genital herpes virus. So most cases of recurrent genital herpes are caused by this HSV2 virus, but an increasing proportion of the genital herpetic infections have actually been attributed to the HSV1 virus, especially among young women, so the population that we're talking to now, as well as men who have sex with men or gay men. And so here are some of the diagnostic considerations and some of the things that can make it difficult to diagnose. So one is it's self-limited, meaning that you'll get it and it will go away. So it's self-limited, it's recurrent. So once you have it, it's going to come back frequently. It can be painful. It can be vesicular or ulcerative, meaning kind of looks like a blister or a wart. And one of the reasons that it makes it difficult to diagnose is because it is self-limited and will go away. You'll have that symptom and then you'll go to your doctor and it won't be there. The lesion won't be there when you actually present for your clinical evaluation. If there is a lesion, when you go to see your doctor, the doctor will diagnose it by confirming it with a specific test for HSV. And this is just an example, not to get too scientific, of some of the tests that are done, but really they're just going to swab the lesion to get you that diagnosis. Now, the big question that most people have is serologic screening, or when you screen the blood for herpes, and that's generally not recommended. In fact, USPSTF just came out in February of this year with a new recommendation saying that for asymptomatic adolescents and adults, including pregnant people, it's not recommended to test the blood. CDC has very similar guidelines. There's very specific recommendations of when serologic testing can be done, but generally speaking, that's not the best way to diagnose herpes. It's by diagnosing a swab from the lesion itself. As I had mentioned before, herpes is a chronic episodic virus. Once you have it, the genital herpes tends to come back. So the guidance on treatment is based off of where you lie in the disease state. So for the first episode, there's a bunch of different options that your doctor will give you. And then because it will come back, there's two options. You can do either what we call suppressive therapy, or you can do episodic therapy. Now, suppressive therapy is a medication you basically take all of the time to suppress or to diminish the likelihood of having another infection, versus episodic, you would take when you start experiencing those symptoms. And a lot of people do prefer the suppressive therapy because it has the additional advantage, one, of decreasing the risk of transmitting the infection to your partner. And two, it tends to decrease the frequency of the herpetic recurrences by about 70 to 80%. So it's nice because you don't have to deal with it as much as you would otherwise. So these are examples of the suppressive therapy. And then these are just examples of episodic therapy. Either way, it's recommended that if you are diagnosed with genital herpes, one of these options be discussed and you have medication at your disposal. So if you choose episodic therapy, when you start experiencing symptoms, you can take the medication. And then Dr. Gerber also talked about pregnancy is a big part of all of this. During pregnancy, we care about herpes, especially because when the baby comes through the birth canal, if there are active lesions there, the baby is at risk of getting herpes. So if you have a history of genital herpes specifically, your doctor will put you on a medication specific for pregnancy starting at 36 weeks. These are the options to prevent an outbreak. So that vaginal delivery is possible. With that, I'm going to shift to syphilis. Syphilis is specifically my area of expertise, so I do like to talk about that a lot. So please stop me if I go too far. But it's also one of the most confusing STIs, sexually transmitted infections. So I do like to spend a lot of time there. And as Dr. Gerber alluded to earlier in the talk, it's rapidly increasing in the United States. So we're seeing a lot more in all communities and all populations. So it's something really important to be aware of. Okay. So again, one of the most confusing STIs, but one of the things that I want to really emphasize before we get started is when we were talking about herpes, I said it's chronic, it's recurrent. Even when you treat that first episode, genital herpes is going to come back, but syphilis is treatable. So if it's diagnosed and you're treated appropriately, it will go away. But that also means it doesn't prevent you from getting it again. So as I go through this, I just want you to keep in mind that this is something that can be completely preventable with appropriate screening and treatment. So syphilis is a bacteria, and you can get transmission of it multiple ways. One is from direct contact of an active lesion during vaginal, anal, or oral sex, as Dr. Gerber was sort of alluding to before, or you can get it transplacentally, so mother to child during pregnancy. And syphilis has many stages. It's very confusing. It's confusing for physicians. I'm going to run through them very briefly just so you're aware of them, but and so you know sort of what the stages are, but this is more just for some general background. So first, syphilis starts with something called primary syphilis, and that's characterized by a painless, so it doesn't hurt, ulcer or chancre is what we call it. And it can be hard to know that you've got it because most of the time it doesn't hurt. Sometimes it does hurt, especially if it's co-infected with herpes. But again, people don't know that they're there because they're in an area where we don't often look. And again, can be asymptomatic. It goes away, importantly, even without treatment. So you'll never know that you had one. Then you get secondary syphilis. This usually occurs about 3 to 6 weeks after primary. And it has a couple of symptoms. The most common one that people will learn about in medical school is a rash, but it doesn't have to only be a rash. And again, these symptoms will go away even if syphilis isn't treated. And here's an example of a rash you might see with secondary syphilis. Now, primary and secondary syphilis are considered the most infectious stages, and they indicate a recent acquisition of syphilis. And they're often lumped together, and you'll see this when we go through the epidemiology, and referred to as P and S syphilis, or primary and secondary syphilis. And then after that, we have something that we call latent syphilis. And latent syphilis is interesting because it's asymptomatic, meaning there's no visible signs or symptoms. And 60 to 85% of people are asymptomatic for years without treatment. So you have primary with the chancre, secondary with this most commonly a rash, but also other just sort of viral, infectious, swollen lymph nodes, just feeling yucky. Sometimes you can get some lesions on your genitalia as well with that. And then latent, where you have nothing, no signs, no symptoms, but again, syphilis is still there. And we divide latent into early latent, which is less than 1 year since the infection, and late latent, which is greater than 1 year since infection. But because syphilis is hard to diagnose, we often don't know if the latent syphilis is falling into that early or late period. So we'll often declare somebody latent syphilis of unknown duration, meaning we know they have syphilis through the diagnosis that I'll go through with a blood test, but we don't know when they got it. Now, I talked about primary and secondary syphilis being lumped together as PNS syphilis, specifically when we talk about epidemiology, but we can also lump early syphilis into primary, secondary, and early latent, being a syphilis infection in the last year. And we lump it that way for treatment purposes. And then after primary, secondary, latent, you can get tertiary syphilis. That's 30% of untreated people with syphilis progress on to tertiary syphilis in 5 to 30 years, so a long time period. And tertiary syphilis is marked by lesions of the cardiovascular or the heart system, usually the aorta, which is shown here, so part of the heart. And you can also get these bone lesions and skin lesions known as gummas. These are just some pictures of the tertiary syphilis. You can also have neurosyphilis, so syphilis that affects your brain, and that can present at any of these stages. And you usually will have meningitis-like symptoms or nerve issues or walking issues or dementia. Now, the other piece to this is congenital syphilis, or CS is how I'll abbreviate it from now on. Congenital syphilis is an infection with this bacteria syphilis in an infant or a fetus that's acquired via transplacental transmission when a pregnant person has untreated or inadequately treated syphilis. And transmission to the baby is highest in the early stages of maternal syphilis, especially secondary syphilis. Though again, transmission can occur at any stage. It just happens to be highest in secondary syphilis. So syphilis during pregnancy is associated with a lot of really bad things: miscarriage, stillbirth, preterm delivery, increased risk of perinatal death, so death around the time of delivery, and a congenital infection. Infants with congenital syphilis who survive can experience lifelong physical and neurologic problems, usually related to chronic scarring. And we divide this into 2 different areas: early congenital syphilis and late congenital syphilis. So here's some pictures of some early congenital syphilis. The manifestations that you'll see here, they appear in the first 2 years of life. They include an enlarged liver and spleen, a rash, you can see here, snuffles, which is kind of a runny nose, central nervous system problems, and bone abnormalities. And the important thing is these will actually go away if you treat the baby for congenital syphilis within an early time frame. Now, late congenital syphilis occurs in children over 2 years old. The classic signs of CS in this late period is something called Hutchinson's triad, which includes complications of the eyes, deafness, and these kind of teeth that look a little abnormal, like mulberry molars is a description we'll use. And there's long-term issues such as skull and skeletal abnormalities and developmental delays, including intellectual disabilities. And these aren't permanent and they won't go away despite treatment. So the good news is we can prevent late congenital syphilis by identifying congenital syphilis in a baby and treating them before the first 3 months of age. So that's great, right? The bad news is that most babies don't have those signs and symptoms of early congenital syphilis that I was just talking to you about. In fact, this slide shows data from what we call the 2021 preliminary CDC data on STDs. And what the important takeaway here, what I want you to focus on, is that the majority of the babies, of congenital syphilis babies, were born alive and had no documented signs or symptoms. So they didn't know they had congenital syphilis just by symptoms alone. And even worse news is that they're not having the symptoms and we're not catching them. So surveillance data from 2014 to 2018 showed that 60 infants were diagnosed with CS after 28 days of life. So really after that time where we could treat to prevent the late congenital syphilis. And here's some examples of some case reports that showed babies who presented later in life with signs and symptoms of congenital syphilis, but did not have a diagnosis at birth. So, but there is some good news here because congenital syphilis can be prevented a couple of ways. One is you can treat infected people of reproductive capacity prior to pregnancy. Or two, you can treat infected pregnant people because treatment of maternal syphilis can actually treat fetal infection and prevent congenital syphilis. So those are the important takeaways for pregnant people. So because of that, we have very specific guidelines about testing in pregnancy. So all pregnant people should be tested for syphilis early in pregnancy. This is part of the bunches of labs that you get at your first prenatal care appointment. One of those is syphilis. And most states actually mandate testing at the first prenatal visit. And you can, depending on where you are, if you get tested and incidentally found to be pregnant in the emergency room, they may consider testing you for syphilis then as well. There's also guidance on retesting people who are at high risk at 28 weeks and at delivery to see if there's new infection that was not caught, at the first prenatal visit. And the important thing that I'd like to show here is there are some individual risk factors, but the other indication for repeat testing is people who live in a high prevalent area. And this is really important because of something that we call sexual networks, which I've asterisks down here. And it's really important to think about because the risk of syphilis and really any STI is not only dependent on individual behaviors, but also on the behaviors of those with whom people are having sex. So for example, a person who has 30 sexual partners in an area with low syphilis prevalence may be less likely to get syphilis than a person who has one sexual partner in an area with high syphilis prevalence. So individual risk factor assessment alone is not enough to determine who is at risk. So now that we've sort of gone over some of the clinical signs or symptoms, I'd like to go through some of the epidemiology. And before we look at this, just a couple of points to raise. syphilis, along with gonorrhea and chlamydia, is considered one of the nationally notifiable STIs in the United States. So every year, CDC puts out an extensive report on gonorrhea, chlamydia, and syphilis. The slides I'm going to show you reflect the most up-to-date reports, with the most recent report being published last spring using 2020 data. But CDC also puts out a preliminary report, and their most recent one they put out was this past July, which shows preliminary data from 2021. So when applicable, I'm going to use the 2021 preliminary data. And when info isn't available with that, I'll use the 2020 data. So let's take a step back and just look at syphilis, because again, we sort of alluded to this, syphilis is increasing and coming to communities near you. Data collection for syphilis began in 1941, and syphilis was made a nationally notifiable condition, so one that was reported to the health department in 1944. And this slide includes data from 1941 through to that preliminary data of 2021. So if you could focus on the gray line for now, that's all I would ask. This gray line represents the rate of total syphilis in the US, which includes syphilis of all stages and congenital syphilis. So what you can see here is that syphilis, again, became this nationally notifiable disease in 1944, and it was really high at that time. And then all of a sudden, it started to drop down precipitously. And that is due to the fact that penicillin became widely available in the US in 1945. Penicillin is the treatment of choice for syphilis. So prior to that, people actually used basically poisons to try to treat syphilis, which wasn't that effective. But here we have this very effective penicillin, and syphilis dropped down rapidly. After this, we saw a slight bump in the 80s that's largely thought to be due to cocaine use. And then when we got to the late 90s, syphilis elimination, so actually eliminating syphilis from all of our sexual networks, seemed to be really possible. And then things were looking good until around 2001, when rates of syphilis began increasing again, and they've continued to increase yearly. And you can see sort of that rise right here. So this slide is from the 2020 STD surveillance report, and what it shows is a breakdown of primary and secondary syphilis by sex, which I'm going to kind of use to transition to a discussion of rates of syphilis in women. In purple, you can see the total rate of primary and secondary syphilis. Again, this is the most infectious stages of syphilis. In green, the rate of syphilis in males, and in black, the rates of syphilis in female. So then what I want you to focus on here is that currently, while more males in that green are reported as having syphilis, rates of syphilis in females are increasing at greater rates than in males. And what I'd also like to draw your attention to is this pink line here, which is the male to female rate ratio. And this is decreasing. You can see how steeply that's decreasing, which indicates that the incidence of syphilis in females is increasing faster than that in males. So while there's more syphilis in the male population, really the population that we have to worry about, because we're seeing really rapid increases in, is women. So this is a really cool animation that shows where syphilis rates in women are increasing. The takeaway point that I want us to get from here is that syphilis in women is present throughout the United States. It isn't just a specific regional issue. And basically everything's leaning blue now, which indicates that syphilis is, again, increasing rapidly everywhere. So I talked about syphilis in the general population. We moved over to syphilis in women. Let's look at syphilis, congenital syphilis. Takeaway for this is that congenital syphilis is increasing as well. In fact, congenital syphilis cases in the United States, as represented by the blue bars, are increasing rapidly. In 2021, preliminary data shows that thus far, there were a total of 2,677 cases of congenital syphilis, which is a 24.1% increase from 2020 to 2021. And what's probably not surprising to this audience is that congenital syphilis cases mirror rates of primary and secondary syphilis in women of reproductive age, as represented here by the black line. So if you think back to that previous map I showed you with the increases of primary and secondary syphilis in women, the map of congenital syphilis cases look pretty similar. And now if you look at the worst outcome, if you think about the worst outcome of congenital syphilis, which would be stillbirth or infant death, you can see that in 2020, 122 congenital syphilis related stillbirths were reported, which is an increase of 28.4% since 2019 and an increase of 838.5% since 2011. And in 2020, 27 congenital syphilis related infant deaths were reported, which is a decrease from 22.9% since 2019, but an increase of 575% since 2011. So we're not doing so great. So how are we going to prevent this from happening? Let's switch gears and just talk very briefly about diagnosis and treatment. Remember that syphilis is very difficult to diagnose. It can be confusing to treat, but we treat it really simply with penicillin. So syphilis is usually diagnosed with 2 serologic blood tests. I won't go into it, but when you get your prenatal package, you'll see that you'll have one test. And if that first test comes back positive, you'll get a confirmatory test to confirm syphilis. And treatment, the mainstay treatment for syphilis is a long-acting penicillin G. Importantly, this is the only treatment option in pregnancy. And it is the only known effective antimicrobial for preventing maternal transmission to the fetus and for actually treating fetal infection in utero. It's given intramuscularly, so as a shot. And if you remember back to when I was talking about the different stages of syphilis, depending on if you're in that early stage or the late stage, you'll either require 1 dose or you will require 3 doses at 1-week intervals for treatment. Importantly, for congenital syphilis treatment, it must be initiated 30 days before delivery to prevent congenital syphilis. So there's also a time frame on it. If you're allergic to penicillin when you're pregnant, the treatment is still penicillin. So people actually have to get desensitized to penicillin to receive the treatment, which is what would happen. And again, adequate maternal treatment of syphilis is dependent, 1, on the completion of a penicillin-based regimen, 2, appropriate for the mother's stage of syphilis, and 3, initiated greater than or equal to 30 days before delivery. If it's not, you'll be considered inadequately treated, and the baby will still be considered a congenital syphilis case. With that, very technical last slide, I'm done with mine, and I'll open it up to the rest of the panel.
Thank you so much, Dr. Machefsky. We had a really informative session, and now we're going to head into the Q&A. Before we start, I just wanted to remind everyone that please keep your questions broad. All questions should be posted in the question box. When you're asking your questions, please hit the Remain Anonymous button in the left-hand corner. Your presence on this webinar is completely anonymous, and we just want to keep it that way. So we have a first question. So this could be addressed to either one of you. If one has been diagnosed with HPV and is dating casually multiple partners, what is important to communicate with said partners and how to avoid spreading this? And to sort of expand upon that, it's having a discussion about STI with partners is not an easy conversation to have. What would you recommend is an effective way to deal with this, to approach it? Any specifics depending on the infection itself?
I think HPV is trickier than other sexually transmitted infections. 1, because it's so ubiquitous. Also because it's not something that is treatable. And it can also be transmitted through genital contact and not necessarily intercourse. So that also complicates things. generally speaking, if somebody, like, I recommend on any type of level, if you're having unprotected intercourse with somebody, you should be at a level, even if it's casual, where you can ask somebody, hey, when's the last time that you've been tested? This is the last time that I was tested, and this is what happened. That should be just part of responsible sex. And so HPV kind of goes hand in hand with that. It's part of that conversation, but it's important for you to be knowledgeable when having that conversation. Like, there's no, if this is a heterosexual relationship and you're female, there's no way for that partner to be tested. He may transmit it to other partners. Likely, some of them have HPV, but it is just so important to have that honest communication, as difficult as that might be.
Dr. Machefsky, anything to add?
I think Dr. Gerber answered that perfectly.
Thank you so much. Okay, we'll be moving on to the next question. This is directed to Dr. Moses. One of the attendees asked, is I noticed that I get a cold sore every time I engage in oral sex with my partner, and it goes away after a couple of days. Could this be related to herpes? Who should be tested for this, myself and or my partner? And is there any way to address this?
Was that for me, Dr. Machefsky?
Yes.
Yeah. So oral herpes is a different beast. I would say if you notice a lesion, I would recommend going to see your doctor to see if you could get tested. Again, the serologic or the blood test is not generally recommended. And when we're talking about herpes in terms of risks for genital herpes, we're looking more at the anogenital region.
Dr. Gerber, is it true that there are no accurate tests for HPV for males?
To my knowledge, this is true.
Mine as well.
If another question is, if I was treated for chlamydia, am I at risk for the complications?
So normally we worry about complications arising from untreated chlamydia. Untreated chlamydia can go travel up the genital tract, as I was mentioning earlier, cause scar tissue on internal organs, which can lead to chronic pelvic pain and infertility. So assuming that it was quick to treatment, then you should be at minimal risk for any long-term consequences.
Thank you. And one more, if I have one STI, am I more likely to get another type?
Yeah, so that's a really good question. We do talk about people who have had multiple STIs being at risk for getting more. And as Dr. Gerber mentioned, there's guidelines and guidance about screening people who have had STIs in the past a little bit more carefully. But again, I do want to stress that sexual network idea, where it really is very dependent on also where you are and who is in that sexual network in which you are participating. That puts you at risk for STIs. STIs certainly have a lot of stigma around them, but a lot of it just has to do with the community in which you are having sex.
Thank you. And this one was also really interesting. If one has HPV and is married with both partners having no prior sexual experience, should they assume their partner is cheating?
I think that's a hard one to assume. Dr. Gerber mentioned there's many different ways that you can get HPV, and HPV is close to ubiquitous. And so I would not go jump to that conclusion. No, I don't have any good solid data on that. But again, that would not be my assumption.
And to follow up, this is for you, Dr. Gerber, about for HPV, are condoms enough of a protection barrier?
Unfortunately, no. Condoms are the best protection barrier and should be used to reduce risk. But because it's not just penetrative intercourse, it can be genital touching, it can be hand touching genitals. So it's just unfortunately much more difficult. So what we talk about is risk mitigation, just make your risks as low as possible. And condoms will do that, but they're not going to be 100%.
Dr. Machefsky, anything to add? All right, question for you, Dr. Machefsky. Can you clarify the herpes response? Did I understand correctly that oral herpes is not a result of having oral sex with someone who has genital herpes?
So it's confusing. There's two kinds. It's probably not clear because there's not a great answer to this. There's two kinds of herpes simplex viruses. There's HSV1, which is traditionally causes the regular cold sore that's not associated with anything to do with sex. It's just a virus. It goes around, you get a cold sore. It tends to come up or flare in times of stress. And the majority of the population is exposed to it by the time they're in their 20s. Then there's HSV2, which has traditionally been thought to be the cause of genital herpes. Genital herpes, similarly to having a painful cold sore on your mouth, you can have a painful cold sore on your genitalia, but it can also, what we found now is that HSV1 can be present as a genital lesion, and HSV2, yes, from oral sex can certainly make its way into the mouth. To say that it is specifically one thing or another is hard to do without having the lesion specifically tested. So you'll see in the CDC guidance, when there is a sore, they recommend not just testing for herpes, but also testing for the type, whether or not it's HSV1 or HSV2. And the HSV2 is generally the one that tends to recur more frequently. So the answer was vague, and I don't know if Dr. Gerber has anything else to add to that with her expertise, because it is unclear.
I think that was very thorough. And it is unclear.
And that is again why the serologic test, you'll see a lot of times people will just be tested with that blood test. And there's not a lot that we can do with that blood test. The blood test is really only helpful in very specific times when we're trying to figure something out, when we know that there's been an exposure or something like that, but it's just too vague. We really rely on actually being able to see the lesion to be able to know what the issue is.
I want to piggyback on that. And I thought because Dr. Machefsky also had the recommendation of a D, so recommending against serologic testing. Just a fun story that CityMD used to include HSV 1 and 2 in their panel of STI testing. And then they found out that basically 70% of New York City was testing positive, and they stopped because there was no clinical significance. So yeah, serologic testing is a tricky.
Dr. Gerber, question for you. How can sex toys be adequately cleaned to prevent the spread of infection?
So generally soap and water, but if you do have like antibacterial wipe, and then to wash with water, because that can be caustic to the vagina. And I recommend routinely cleaning toys.
Thank you so much. Last question of the night. Should every married couple regularly be tested, and how often? Dr. Machefsky, please.
So in terms of guidelines for screening, there are guidelines out there, and they exist largely, as Dr. Gerber mentioned in her talk, when we're talking about who is at the most high risk and where is it going to be the most essentially bang for your buck for screening for things. So as she mentioned with gonorrhea and chlamydia, if you are under the age of 25, that's going to come, and sexually active, that's going to come with a recommendation that you get yearly testing. In pregnancy, we have very specific guidelines for STIs as well, because again, we're trying to catch people with STIs to prevent transmission to babies. I would say there's no standard guidelines, but for people in a monogamous relationship who are 40 years old without additional risk factors like carrying a diagnosis of HIV or a diagnosis of syphilis or something like that. But STI testing is something that I ask about at every well woman exam, regardless of the relationship that you're in. And so that is something that is freely available always. And if that makes you feel more comfortable, I don't know any OBGYN who would say no to that. You'd probably get that question at every well woman exam. Would you like STI testing? I don't know if Dr. Gerber has anything to add.
I second that.
So thank you so much. I would like to thank everyone. Thank you for registering for JOMA's webinar about sexually transmitted infections. I would like to thank once again Dr. Gerber, Dr. Machefsky for your time and willingness to teach us today. It was very informative, and I think we had a great, fantastic session. Thank you to the JOMA Women's Health Committee team for organizing this event, and of course to all of our attendees for joining.
A pleasure. Thanks for having us.